first line where you see someone who, with de novo metastatic prostate cancer treated with triplet approach, now develops CRPC, what's your next move? So 2 years later.
Yeah, I mean, I'm thinking that radioligand therapy might be gives the best advantage with survival.
Well, right, PSMA-4 trial basically in patient, the original lutetium PSMA indication for someone who has to receive docetaxel in a castration-resistant setting, and before you can offer lutetium PSMA. Now the PSMA-4 basically in patient without receiving docetaxel or refuse to receive docetaxel, those patients will be randomized to lutetium PSMA versus another ARPI, which we know that is inferior based on the CAR trial, right? So that's definitely one of the options. Alex, what else would you consider in the first-line CRPC setting?
So if somebody has previously received triplet.
Triplet or doublet?
Right. So if somebody has received doublet, then standard options would be to use docetaxel or to use Pluvicto based on the PSMA-4 data for patients who refused or were ineligible for docetaxel. So those are both very reasonable options. Certainly, PEACE-3 presents an interesting option of using, for those who didn't receive doublet, certainly, then to offer them enzalutamide plus radium-223. The alternative options would be ARPI switch, although we know that that's inferior to the use of Pluvicto. The other consideration would certainly be that if they have a BRCA2 or other HRD mutation, then this introduces a number of other options, primarily based on data from PROfound and Triton, the use of olaparib or rucaparib. And then, we have 3 different doublet options for ARPI plus, although those are in patients predominantly who've only received ADT.
That's right. That's right. Yeah. So a lot of exciting changes going on in the field of prostate cancer, and how are we going to integrate all these changes, the new clinical trial data into our daily clinical practice? It's a challenge. How do we deal with that?
I don't know. I think you just have to try to look at the patient and pick the best option you think for the person in front of you. Age, comorbidities. I think one of the biggest questions we have to ask ourselves with prostate cancer is kind of what NCCN has always asked us. What is their life expectancy? What is their life expectancy without the cancer? And then I think you kind of cater your treatment based on, that factor including, what you think they can tolerate.
Yeah, the real world population is always different from clinical trial population, right?
Most of the time it's not entirely relevant.
It's not the challenge to integrate the clinical trial data into daily practice. And go ahead.
I mean, I think, one of the things sort of I think about in terms of the future and management of metastatic prostate cancer is, sort of the integration of a personalized approach, which takes into account very much, patient-specific factors like age, comorbidities, goals of care, of course, but also, molecular profiling. How do we use that to guide us? Will that impact treatment in the first line in castration-sensitive disease? Can we use, for example, radiomics or other features that can guide who will best respond to drugs like Pluvicto or better respond to radium? Can we, are there features of patients' disease radiographically that can predict sequencing, can predict whether ARPI would be, better, or, whether an androgen receptor antagonist would be better than abiraterone, for example. So I think that, as we move forward, we'll have to develop sort of better tools and use the tools we have to kind of come up with comprehensive plans for each patient.
So using biomarker to predict treatment response, we know in the subpopulation of, HRR mutation population, this patient benefit from PARP inhibitors or either alone or in combination with another ARPI. And there's also recent data suggests patient with PTEN mutation or PTEN loss, those patient population may have higher sensitivity to docetaxel based on what the abstract presented in the ASCO meeting. So there are a lot to look forward to, and there's some exciting trials coming up. There's newer treatment will become available for P10 loss prostate cancer in hormone-sensitive setting. The PARP inhibitors are moving to the front line in the hormone-sensitive setting. The amplitude was presented in the ASCO meeting with positive result with the improvement to RPFS. And there's ongoing trials evaluating PARP inhibitor in the hormone-sensitive setting. And in the castration-resistant setting, there are several new compounds and completely different class. EZH2 inhibitor, for instance, is coming up. And very impressive data in the phase 1, phase 2 setting. And the phase 3 study will be open. Well, it has been very interesting discussion, and we have learned a lot from each other's practice and scenarios, and hopefully we continue the conversation in our daily practice. Looking forward to work with you in the future.